Hello, my name is Robert Hudak. I'm an associate professor of psychiatry at the University of Pittsburgh School of Medicine. I am the director of the OCD intensive outpatient program here at the University of Pittsburgh's Medical Center. And today I'm going to talk about obsessive compulsive related disorders. So, this is going to be a general overview of all the obsessive compulsive related disorders. And to let you know, I have one disclosure. I have a book at Springer Nature Press, and some of the slides from my lecture are taken from my book. All right, so first let me talk a little bit about obsessive compulsive and related disorders. Now, in DSM-4, there was no such thing as obsessive compulsive related disorders. Obsessive compulsive disorder was considered to be a form of anxiety, was considered to be one of the anxiety disorders. We know now, of course, that is not the case. OCD is not an anxiety disorder. It's not a disorder of anxiety. OCD causes anxiety, but it is not caused by anxiety. Therefore, OCD is not an anxiety disorder. And there are other disorders that existed throughout DSM in various kind of random places that were actually much more closely related to OCD than where they were. So these were all grouped together into a single chapter under obsessive compulsive related disorders. So of course, the first obsessive compulsive related disorder is OCD itself. And I've listed here, there are specifiers for OCD. There's insight, which is good or fair, poor, absent / delusional, and tic related. Another OCRD that is there is body dysmorphic disorder, and it has specifiers, again, of good or fair, poor, absent / delusional. There is excoriation or skin picking disorder. This disorder did not exist in prior editions of DSM. There's trichotillomania or hair pulling disorder. There is hoarding, again, another disorder that was not listed in prior DSM. And then we have, of course, substance medication-induced obsessive compulsive and related disorder, and obsessive compulsive related disorder due to other medical conditions. They both have specifiers as well. One thing I would like to point out with these specifiers, especially when we're talking about insight, when we use the term delusional insight in the various obsessive compulsive related disorders, and you see that that is a specifier for both OCD, BDD, and for hoarding disorder. Delusional insight does not imply that the patients are delusional. In other words, these patients aren't psychotic. We're using the term delusional insight, but that doesn't mean they're actually delusional, and it doesn't mean that antipsychotics are indicated in these patients. So that's an important distinction to be made. Then there are the other specified obsessive compulsive and related disorders. These are very important. You have BDD with actual flaws. There's BFRB disorder, which are just basically any of the body-focused repetitive behaviors that aren't either skin picking or hair pulling. And then an important one that I see come up quite a bit is olfactory reference syndrome. This used to be thought of as a delusional disorder, and these patients were treated as delusional disorders, and we realize now that it's actually a form of an obsessive compulsive related disorder, probably a form of body dysmorphic disorder that has nothing whatsoever to do with the delusional disorder, even though they look like they're delusional. And then, of course, we have the unspecified category, which is used when you don't have time to make a full evaluation, but you see some signs of something that is OC related. So let me start off by talking about OCD. So what's the epidemiology of OCD? Originally thought to be a very rare illness. And when I was first training, OCD was thought to be something that a psychiatrist may see just once in their career. We know now that it's one of the most common of all the psychiatric disorders, affects about 1 in 40 people. It is unusual in psychiatric disorders in that it is equally common in men as well as women. And if you look at the WHO statistics from the World Health Organization, it's one of the top major causes of all disability in the world. And that's medical and psychiatric disability. It can be as high as 10 in many of the yearly surveys. So OCD is a really severe disabling illness that's very common. I always like to say that the diagnostic criteria for OCD is probably the easiest to make in all of psychiatry. It is a dimensional category. It is not the typical categorical, you need 4 of 9 type of symptoms, that type of thing. To have OCD, you either have to have obsessions or compulsions. They have to be recognized as excessive and cause distress and are time consuming. So what's important to note here is that for OCD, you need to either have obsessions or compulsions. You do not need to have both. Many people have both, but they don't all. One person told me just a couple of days ago that they had a lot of intrusive thoughts after their son was born. Thoughts that their son was going to die in a car accident and was unable to get in the car and drive because of that. And the doctor said, "Do you have any compulsions?" And the patient said, "No, I just have all these weird intrusive thoughts about my son dying." And the doctor said, "Well, it can't be OCD because there's no compulsions." Again, you can either have obsessions or compulsions. You don't have to have both. So what is an obsession? An obsession is a recurrent and persistent unwanted thought, urge, or image that's inappropriate, intrusive, causes marked anxiety. These aren't real life worries. These aren't real life problems. The patient knows that these thoughts are ridiculous but can't control them. And notice that they're not just thoughts. The DSM criteria also says urges and images. So people can be afraid they're going to do something, afraid they're going to harm somebody, afraid they're going to do something they don't want to do. They can also get visual images, and they may even describe them as a hallucination because these visual images can be very strong. Again, this is in the criteria, so these are normal for OCD. A lot of people think of OCD as just a fear of germs, but the thoughts, urge, and image are quite typical here in OCD. Now, the most common obsessions, things like contamination, pathological doubt. Did I turn off the stove? Did I lock the door or not? Somatic obsessions, symmetry, needing to line things up. Aggressive, sexual obsessions, very common in people. Worried they're going to hurt somebody, worried they're going to rape somebody, worried that they're a pedophile, worried that they're the wrong sexual orientation, whatever. Again, all symptoms that are very common, and most people have multiple obsessions. And just to drive this point home, that the DSM criteria says that patients can have that obsessions can be thoughts, images, or urges. But obsessions can also be sounds. There are numerous case reports, and I see this all the time. People have obsessional sounds, often something in their head, a music song playing in their head that they can't get rid of, someone's voice in their head that they can't get rid of. They may describe them as a voice or an auditory hallucination. But again, obsessions can very commonly present this way. In fact, obsessions can also present as virtually any of the five senses. So you can get obsessional smells, which again happens in olfactory reference syndrome. You can get obsessional tastes as well. And sometimes that can be confused with delusional disorder. And then there's something called obsessional slowness, which can be confused with catatonia because patients are just simply afraid to move or simply afraid to make any kind of decision. What is a compulsion? A compulsion is a repetitive behavior or mental act that the person must perform. And in the short term, it reduces the distress of the obsession. So the compulsion is done in response to the obsession. It reduces the distress that the obsession causes. But then, of course, the obsession comes back even stronger. So these are the most common compulsions. And I think what's important to note here is that the numbers you'll see don't always precisely line up with the most common obsessions. And the reason for that is that obsessions and compulsions don't have to match up. They don't have to make sense. And one of the things I always teach about OCD is that the symptoms don't make sense. Don't try to logic someone's symptoms out. If someone has a problem with germs or contamination, you may say, aha, that means their compulsion is cleaning. That is not necessarily the case. Their compulsion could be praying. It could be checking. It could be chanting. They could do other things that you may consider non-logical to get rid of contamination on your hands, but that's what their OCD tells them to do. So again, OCD is very non-logical. It doesn't make sense. So don't try to make sense of your patient's symptoms. Don't try to make sense of why someone's doing a compulsion to an obsession. The fact that they're doing it is enough. So compulsions are usually thought to be an active act, something you are intentionally doing. But it's important to note that if a compulsion is severe, they can develop into passive avoidance. So not doing something can be a compulsion as well. So in the patient I talked about earlier who had these intrusive thoughts about their son and them dying in a car accident, they didn't have a compulsion per se, what we normally think of compulsion, but they stopped driving. They stopped putting their son in the car for fear their son would get into an accident. Well, guess what? That actually is a compulsion. Not wanting to drive, being afraid to drive, and not getting in a car is a compulsion. So avoidance is a compulsion. Okay, so there's a lot of high comorbidity associated with OCD. About 2/3 of people with OCD will have major depression at one point in their lifetime. There's a high crossover with social phobia, eating disorder, alcohol dependence, panic disorder, and you can see a very high rate of Tourette syndrome in people with OCD. If you take a look at the rate of OCD in people with Tourette syndrome, it could be as high as half, depending on what author you read. Okay, there's a lot of reasons that OCD is fairly under-recognized by mental health professionals. We know from studies it can take 10 years before someone with OCD presents to a physician, and it can be 5 years or more until they get a proper diagnosis. And I will say I see this all the time. People are in mental health treatment for years and years before their mental health practitioner says, oh, this is actually OCD. This isn't depression. It isn't anxiety. It isn't schizophrenia, whatever. The OCD gets confused with all those things. A lot of this is because most people with anxiety disorders and OCD-related disorders are not seen by mental health specialists. Patients don't like to talk about their symptoms because OCD causes shame. That's one of the symptoms of it. And we fail to screen sometimes for OCD during mental status exam. And I said the big one is misdiagnosis of symptoms. OCD is often misdiagnosed virtually. I've seen it misdiagnosed virtually every other psychiatric disorder. Schizophrenia, very common. There's a lot of people out there with schizophrenia diagnoses who actually have OCD. These are some screening questions for OCD. I think these make a nice way to generally screen during a mental health examination. If you ask about washing your hands or checking things, you hit about half the patients, but have thoughts that bother you or make you anxious, thoughts you can't get rid of or don't make sense. You're going to hit a lot more people with that one. And so these are really good screening questions for OCD. So some more epidemiological information. The average age of onset is 20 years. That's according to the data. I will say that in my practice, and most people will say that earlier age of onset seems to be most common. I see mostly people with age of onset in their teenage years, and I see plenty of patients who say that their very first thoughts are OCD. Another area that OCD is a little unique in psychiatry is that the symptoms of OCD are virtually the same in children as they are in adults. Men have an earlier age of onset than women for OCD, and that's because checkers have an earlier age of onset than people who have contamination. And guess what? Men are more likely to be checkers. Women are more likely to be contamination cleaners. That's why men have an earlier age of onset. So the course of OCD, this is considered to be a chronic disorder. I tell patients when they have this, they're going to have it the rest of their life. Most people have episodic with incomplete remissions. In other words, the OCD waxes and wanes. It gets better at times, it gets worse at times. There are some people that have a continuous course where the OCD is pretty much continuous the whole life and can even cause a deteriorative course where they just get worse and worse and worse. There are also a small number of people who have what's called phasic OCD, where they have OCD, but they have complete remissions in between episodes. But I said most people have incomplete remissions in between their episodes. Okay, now let's move on. I want to talk about hoarding disorder. And let's go over the DSM-4 diagnostic criteria for hoarding disorder. And of course, there's nothing on this slide because, as I said, DSM-4 only mentioned hoarding disorder briefly in the criteria for OCPD, which we know now that obsessive compulsive personality disorder is not related at all to hoarding. And just as an aside, obsessive compulsive personality disorder is not at all related to OCD either. There's no crossover between OCD and OCPD. There are disorders that are very, very different that just unfortunately happen to have almost similar sounding names. And that was due to an artifact, a mistake that occurred in DSM-3 that was never really corrected. Okay, DSM-5 hoarding disorder criteria. So this is a new disorder in psychiatry. So persistent difficulty in discarding or parting with possessions, regardless of their actual value. And the difficulty is due to a perceived need to save the item and a distress associated with discarding the item. And the difficulty in discarding these possessions results in the accumulation of possessions that congest and clutter living areas and substantially compromises their use. And so that's a key with hoarding. With hoarding, there has to be such amount of clutter that you can't use something for its intended purpose. The bed, you can't use it as a bed. The couch, you can't use it as a couch. Table, counters, you can't use them because there's too much clutter on them. If living areas are uncluttered, it's only because of the interventions of third parties, family members, authorities, whatnot. And so again, it has to cause clinically significant distress or impairment and not attributable to another medical condition. Brain injuries can often lead to hoarding disorder, as well as things like Prader-Willi syndrome. And of course, is not better explained by the symptoms of another mental disorder. There are people in OCD who have what we call OCD hoarding. They're not true hoarders. They have difficulty throwing things away because the rituals involved in throwing things away, such as checking, are so extensive that they have a hard time doing it. So people who have decreased energy, anergia, and MDD, delusions, and schizophrenia, none of those people meet the criteria for hoarding disorder. Okay, there are some specifiers: excessive acquisition. So many people with hoarding disorder, and probably the majority of people with hoarding disorder, not only do they not throw things away, they go out and extensively collect. They will go and try and find as many things to bring in as possible. So they'll buy or they'll steal things to bring into the house. And again, there's insights: good or fair, poor, absent / delusional. The people with hoarding disorder tend to fall more on the poor to absent / delusional, whereas with OCD, it can fall more evenly along the whole spectrum. There's more likely to have better insight for OCD than there is for hoarding. Again, as I specified earlier, just because you have what's called delusional insight in hoarding disorder does not mean the patients are delusional. It does not mean that they require an antipsychotic, and it does not even imply that antipsychotics work in those people, because actually they don't. But we'll get to that later on. So the clinical features of hoarding disorder. So again, most people have excessive acquiring, 80 to 90%. These people, they just don't discard their possessions either, and their clutter makes the living space unusable and significant distress or impairment. So this is basically just the DSM-5 criteria boiled down to the clinical features and what you would expect to see in someone who has hoarding disorder. So what happens with hoarding disorder? What happens is they have a very strong attachment to objects. And what you may consider trash, they consider to be a treasure. They have a heightened sense of responsibility toward this object and an emotional attachment to this possession. So for example, if they ordered a pizza and had have the pizza box at home, and then they got a phone call from a loved one, and it was a nice phone call, they may say, I need to save this pizza box because it reminds me of this wonderful phone call I have. And so they won't throw away the old greasy pizza box. And this is very common in people with hoarding. So they have these attachment to all the various objects that they have. They do not sort, organize, and they don't properly discard their clutter either. So this is how you distinguish between a collector and someone who is a hoarder. So if you have someone who collects, for example, sports memorabilia, they have things sorted. Like, here's my baseball section, here's my football section, or here's my section on Roger Staubach, here's my memorabilia, here's my selection on Jim Brown memorabilia, whatever. Okay, that's how collectors do. So even if they look cluttered, that's what a collector mentality is. It's not like that in hoarding. You won't see, here's all my old pizza boxes over here. You won't see, here's all my old magazine flyers over here. Everything seems to be kind of disorganized, and there really isn't that sorting involved with it. And of course, people, because of the low insight, they're just simply not motivated for treatment very often, unless they're forced to. So the epidemiology of hoarding may be as high as 5%, which would mean it's twice as common as OCD, and which would mean OCD is already the fourth most common psychiatric disorder. Again, because hoarding disorder did not exist as a psychiatric disorder prior to 10 years ago when DSM-5 was published, there wasn't a lot of information about it with research, because of course, how do you do research? How do you get a research grant if for a disorder that doesn't exist. So again, there's a lot yet about hoarding disorder that we don't know, but the prevalence seems to be high. Most cases do not meet criteria for OCD. And as I said, that hoarding disorder was mentioned as a symptom of OCPD, but it's been found that there's no correlation between that. There's no correlation between hoarding disorder and OCPD. So those are really kind of not relevant to each other. And as I said, there's also no, just to reemphasize, there's no crossover between OCD and OCPD. These are two disorders that the names sound alike. They're just completely different etiologies. So hoarding disorder often begins in childhood, but it's more prevalent in adults. And the reason for that is simple. When you're a child, your parents can make you clean your room. We don't know yet about relationship with gender or race. Is hoarding disorder one disorder? Is it many disorders? We don't know that yet, and there's still research is ongoing. But 2/3 of health departments will receive a complaint about a hoarding patient within the last 5 years. And most of the times they're reported by the neighbors. And that's what happens when the clutter extends beyond the home. So the clutter starts moving into the yard, into the car, and smells will often trigger that health complaint. People have died from hoarding disorder. And everyone who lives in New York City knows about the famous case there of the brothers who died in their hoard. Many years ago. The work impairment with hoarding disorder is similar to psychotic disorder. So that's how severe the impairment with hoarding disorders is. So significant family consequences, decreased rates of marriage, and 1/3 of the people are below the poverty line who have hoarding. So a biopsychosocial model, we know that there are significant cognitive deficits, maladaptive behaviors. In other words, there's significant executive dysfunction in people with hoarding disorder. There seems to be a genetic transmission. So it is something that is, there's an inheritability factor in here. There seems to be a high relationship between trauma and hoarding. And again, this hasn't been sussed out yet, but there seems to be higher amounts of trauma in people with hoarding disorder than the general population. They have decreased in attention and memory, and yet their memory is overtaxed. It's a little bit of a contradiction. So they can't remember things. They have this executive dysfunction, but they'll know where all the various pieces of their hoard are. So again, this is something that really needs to be studied, and we need to know more about. So the vast majority of patients with hoarding disorder have another axis 1 or axis 2 disorder. This is old DSM terminology, but it's there because of old research, so I kept it as it is. Dementia, organic brain syndromes, very common in comorbidity. Personality disorders are very common in hoarding disorder, but interestingly, not OCPD. So the other personality disorders, however, can be common as a comorbidity. ADHD and impulse control disorders, very common comorbidities with hoarding disorder as well. Now, how I approach hoarding disorder diagnostically is first determine, is there clutter in the house? Is there too much stuff in the house that makes it so that their living surfaces are unusable? There are rating scales available for this. You can find some of them online. They're basically just pictures, and pictures of various amounts of clutter. And you can have people point to what their house looks like. What's their clutter rating? If there is clutter, determine if a psychiatric illness is present, or are they just someone who is there a medical reason for this? Is there another reason for the clutter that isn't psychiatric? Then if you know it's psychiatric, you want to distinguish, is it hoarding or is it OCD? Because OCD hoarding, again, is very different than hoarding disorder. If you determine the patient has hoarding, then you have to examine for all those comorbidities that I discussed earlier. That's kind of my algorithm, the stepwise way how you have to approach concerns about clutter and hoarding. So let me move on and talk about body dysmorphic disorder. So let's talk about the DSM-5 criteria for body dysmorphic disorder. So this is preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or slight to others. In other words, these people look normal. They perceive themselves as deformed, hideous, or ugly in some way. At some point during the course of this disorder, this patient has performed repetitive behavior. So mirror checking, excessive grooming, skin picking, or reassurance seeking, or mental acts in response to their appearance concerns. Okay. The preoccupations cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. The preoccupations are not attributable to another medical condition. Okay. And just so you know that these appearance preoccupations are not better accounted for by concerns by body fat or body weight in an eating disorder. So the symptoms of BDD can look quite a bit like the concerns about body weight in an eating disorder. It is different. They are different. So that is a important rule out that you need to make with that. There are specifiers, muscle dysmorphia, and this usually occurs in men who worry that their muscles aren't big enough. And insight in body dysmorphic disorder, good, fair, poor, absent. And it's important to note that, again, as I mentioned earlier, with BDD, the poor, absent / delusional type insight is more common in BDD than it is with OCD. Okay. BDD can occur in all age groups. It can occur in children, it can occur in adults, it occurs in the elderly. It usually begins in early adolescence, similar to OCD. And in fact, of all the obsessive compulsive related disorders, BD is probably the one that is the closest to OCD. There's only a slight female preponderance in body dysmorphic disorder, a 3-to-2 ratio. The features are similar in both genders, and there's still some questions about, is there differences in BDD in different cultures? And that's something that is still being worked out. Clinical features, so these are people with obsessions, preoccupations about their appearance, and they will spend hours a day worried about their appearance. Typically, the face, head, and hairline are what is their concern, but can really occur with any body part. And most people with BDD have multiple body parts. Okay. Now, again, insight is usually poor or absent. They will often worry about being mocked, and they will often talk about being mocked. They will talk about they're worried that people are trying to harass them or making fun of them in some way. So they will say, I'm paranoid. And so, again, people with BDD can often be confused with a psychotic disorder because of their constant complaints about paranoia and being mocked whenever they are outside the house. Their preoccupations are taking 3 to 8 hours a day. So they will spend most of the day worried and thinking about their supposed deformities. So there are some important differential diagnoses with OCD, with BDD. So OCD with somatic obsession. So people with OCD will have obsessional somatic concerns that needs to be looked at. Hypochondriasis, again, a somatic obsessional type disorder. Delusional disorder, it's important to note, again, many people with BDD, they can look to be delusional because their insight is so poor. They will be convinced that they're ugly. They will be convinced that people are mocking them. It can really seem delusional. They can have this delusional level of insight. Again, even though we call that delusional level of insight, it is not considered psychotic. And I'm going to discuss that not only do antipsychotics not work in BDD patients, there's actually some evidence that shows that antipsychotics make people worse, and that even includes the people who are so-called delusional. And again, the other one is social anxiety disorder. Social anxiety disorder patients will often complain that they're being mocked when they're out in public as well. There are a couple other features of body dysmorphic disorder that are worth to think about. The checking behaviors that people have are usually involve hiding or fixing their perceived deficits. It could be the way they wear their clothes, makeup, hair, just some way that they arrange them to hide their deficits. What's important to note here, however, in BDD is that these compulsions do not make the person feel better. So with OCD, when they perform a ritual, their obsessions are temporarily better. With BDD, that's not the case. When they perform a ritual, they actually feel worse. And so they perform more rituals, and they end up feeling worse and worse. And it's a big downward spiral. So people with BDD can spiral downwards really quickly. Okay, so what are the types of compulsions that people with BDD can have? They can have excessive grooming, styling, plucking, shaving, touching affected areas. So they'll often touch the area that they are afraid that they have the BDD with. Asking for reassurances, am I ugly? Am I hideous? And they'll do a lot of that. Compulsive tanning to hide skin defects is very common in people with BDD. So when you see people who are rigid tanners, that's something to keep in mind. Skin picking to get rid of defects. again, is very common as a compulsion in BDD. Now, another compulsion that you have to be very aware of is self-surgery. Self-surgery is something that happens not uncommonly in people with body dysmorphic disorder, and maybe an exception to the rule that BDD patients look normal. So people with BDD, because of their self-surgery, they can appear deformed because it's really difficult to perform surgery on yourself, particularly if you're not a physician. So skin picking is considered to be a form of self-surgery, but people have used pins, needles, razor blades, and knives as implements of self-surgery. Dr. Phillips, who's the pioneer in this field, talks about the one patient she had who no doctor would give the patient a rhinoplasty, a nose job. So the patient got a piece of chicken cartilage and inserted it themselves into their nose in order to make their nose appear more normal. So as you might guess, people with BDD quite frequently go to seek surgery or dermatological treatment, as well as dental treatment. And those are probably the three things that BDD people will do the most. So plastic surgery, dermatology, about 75% do. I see dental a lot as well in there. So there's kind of the three areas, cosmetic dentistry, where you need to worry about. It does not work. If you do plastic surgery on BDD patients, the obsessions continue, or they just focus on new areas. So we do not recommend that BDD patients have plastic surgery. And this includes, by the way, patients with that would have BDD with actual flaws. So that would be diagnosable as other specified obsessive compulsive and related disorders, BDD with actual flaws. That's what that diagnosis is. Those patients, we do not recommend plastic surgery even for those. Now, 40% of surgeons have been threatened by a BDD patient. Anytime I hear about a surgeon, like a plastic surgeon, being murdered, one of the first things that always come to my mind is, was it a BDD patient? There are two reasons why surgeons get killed, is by pain patients and by BDD patients. And so that's why I try to reach out to surgeons quite frequently, because this is such a serious problem for them. 80% of people with BDD will have suicidal ideations, and 25% will make a suicide attempt at some point in their life. If a dermatologic patient dies by suicide, it's usually because of acne or BDD. And the annual suicide rate of BDD patients is 0.3%. That makes BDD the highest among all psychiatric disorders in suicidality. And that's something that's going to come as a surprise to a lot of people hearing this lecture, but probably the very highest risk of suicide among any psychiatric disorder is BDD, higher than major depression, higher than bipolar disorder. And yet we are underdiagnosing and misdiagnosing these people. And when we do diagnose them, we often don't treat them correctly. So I think we're doing our patients a major disservice here. So I think that in order to really better intervene in this serious risk of suicidality, as well as homicidality, and to our surgeon colleagues, we need to do a much better job of identifying and treating body dysmorphic disorder. Quality of life with BDD, very poor. And they have a poor quality of life, worse than MDD, worse than PTSD. Almost half of people with BDD have been hospitalized. 1/3 are unable to work or go to school. And people with BDD are much less likely to marry, even more so than OCD people. So again, people with BDD just are very unlikely to marry. So what kind of diagnostic questions do you ask, and how do you screen for body dysmorphic disorder? I have some helpful hints here. Don't ask someone, are you worried about an imagined defect in appearance? That person is going to get up and walk out because they don't have an imagined defect. They have a real defect in their mind anyway. So ask instead, are you unhappy with how you look? Ask about other areas of the body other than what they mentioned, and ask, does this concern preoccupy you? I don't know too many people who are totally 100% happy with how they look, but most of us don't spend 3 to 8 hours a day thinking about it. How much distress does these concerns cause you? I wish I looked like Brad Pitt. I don't spend 8 hours a day thinking that I wish I looked that good, and it causes me zero distress. So again, this is why these diagnostic questions can be helpful. You must rule out an eating disorder. And again, ask about common compulsions, tanning, weightlifting, very common, concealing and touching. And then you need to screen for the other common comorbidities, obsessive compulsive disorder, social anxiety disorder, major depressive disorder, substance use. And once you've done all this, I recommend that you establish alliance with the patient, and you have to provide psychoeducation. Take their concerns seriously. Explain that what they have is BDD. So not what they you don't want to tell them their concerns aren't real. Their concerns are very real, but the concerns are from body dysmorphic disorder. And you want to discourage surgery. You tell them, I don't think surgery is a good idea here with you. We want to use CBT. And the idea of the CBT is to decrease their excessive preoccupation. So these people have obsessions about their bodies, and they are excessively preoccupied with these obsessions, going 8 hours a day. So we want to decrease the preoccupation with their bodily obsessions. And you can let them know that. Surgeons, dermatologists, surgical intervention does not work. Again, we just cannot stress this enough. State you recommend against it. And even if the person is one of those other specified obsessive compulsive and related disorders, BDD with actual flaws, that's kind of a mouthful to say that diagnosis, but that's the official diagnosis. Even if they have that, ask them that they delay their surgery until after they've had psychiatric treatment and after their BDD is properly treated. Tell patients that effective treatments for BDD exist, and give them reading recommendations. And I recommend The Broken Mirror by Catherine Phillips. Catherine Phillips is the leading pioneer in body dysmorphic disorder. She essentially invented this field, and she was the leader of this section of the DSM-5 work group. And Broken Mirror is an excellent book. And again, any patient who has BDD or anyone with a loved one with BDD should be reading The Broken Mirror. So let me move on, and let's talk about what's called trichotillomania or hair pulling disorder, and what's called excoriation or skin picking disorder. And so the DSM at 5 at this point allows both names to be used. I generally prefer hair pulling disorder and skin picking disorder. It's kind of a personal preference. My reason for that is that trichotillomania, I think, is a bit of a misleading term because it has nothing to do with mood. There's no mania component to that. Okay, so hair pulling disorder used to be classified as an impulse control disorder. It is not an impulse control disorder. It has nothing whatsoever to do with impulses. It is urges. It's not an impulse. Skin picking disorder was not recognized. Skin picking disorder was not in DSM at all prior to DSM-5. So the illnesses for hair pulling and skin picking have similar phenomenology and etiology. Treatment is the same for both. They really can be considered and grouped together for the most part. And by the way, for the other specified obsessive and compulsive related disorders, body focused repetitive behaviors, and again, that's a mouthful, but that's the official diagnosis. So the other, these would include things like nail biting, chewing on the nails, cheek chewing, lip licking, toenail biting. Okay, all of these things would be considered to be other specified obsessive compulsive related disorders, body focused repetitive behavior. Again, it's a mouthful. We call it BFRB for short. These can all be treated and really thought about in the same way. My own personal guess is that in future editions of DSM, we're going to get rid of all these individual diagnoses, and it's just going to be called BFRB disorder, body focused repetitive behavior, and we'll just all consider it to be one thing. But again, we're not at that point yet, and that's just my own personal opinion. So let's talk about hair pulling and skin picking disorder. So the criteria now simply state that the excoriation or hair pulling cause significant distress or impairment. The diagnosis and treatment of people with anxiety or pleasure from BFRBs, high awareness, low awareness, these were all taken out of DSM-5. So DSM-4 talked about, is there anxiety with it? Is there pleasure? Is there increasing tension? Is there high awareness? Is there low awareness? And what we know is that pretty much everyone with a body-focused repetitive behavior has all of this stuff. So there's really no need for that to be in there in the diagnostic criteria. So that was just taken out at DSM-5. So simply, I'm going to go over the specific diagnostic criteria here, but really it just simply states that you skin pick, you pull your hair, you do some other body-focused repetitive behavior that causes significant distress and impairment. And that's really kind of the bottom line. So hair pulling disorder. Recurrent pulling of one's hair resulting in hair loss. Patient makes repeated attempts to decrease or stop it, and it causes clinically significant distress. It is not due to another medical condition, not better explained by the symptoms of another mental disorder, In other words, attempts to improve a perceived flaw in appearance in body dysmorphic disorder. Okay. Skin picking, you're going to read this, reads almost exactly the same. Recurrent skin picking resulting in skin lesions. Repeated attempts to decrease or stop skin picking. And skin picking causes clinically significant distress or impairments in social, occupational, and other areas of functioning. So not attributable to physiological effects of a substance such as cocaine or scabies, and not explained by other mental disorders such as delusions, tactile hallucinations, attempt to improve appearances, stereotypies, self-injurious behavior. So hair pulling disorder. So people may attempt to pull specific hairs, or they may just pull their hairs. Often patients are looking for a hair with a root attached. So they may want to pull their hair and you get the root attached. There's like a little nub at the end, and they may rub that root on their lips. They may mouth it. They may put it in their mouth. They may even eat the hair. And so a trichobezoar is a possible medical complication of hair pulling disorder and can require surgical intervention. So excoriation disorder, again, this can cause mouth scabs, the skin they pick. They can play with that. They can mouth their scabs. Patients do not report pain while they're picking or while they're pulling their hair, by the way, although it can be present afterwards. So in other words, if you ask someone with hair pulling disorder or skin picking to go ahead and just pick their skin or pull their hair, it's going to hurt them. When they're doing it as part of the disorder, there typically isn't going to be pain. Excoriation disorder can lead to tissue damage, scarring, amputation, infection, and I have had patients die from excoriation disorder. So this is a potentially fatal illness. So you do absolutely need to be aware of that. The disorders are markedly underdiagnosed, and excoriation, skin picking disorder, is markedly underdiagnosed. The reason for that is that most people consider this to be, quote, a habit, end quote. Or they consider this to be, quote, anxiety, end quote. And so they don't report this to you that they're picking their skin. Even a lot of times doctors, when they see it, they don't realize that skin picking is a separate standalone disorder with evidence-based treatment. They see someone picking their skin and they say, oh, you must be anxious. Let's treat you for anxiety. So remember, these are separate standalone illnesses that have evidence-based treatment. So a proper diagnosis is important in order to get proper treatment for your patients. So with both of these disorders, you have to note that the sites can change over time. So they're not always necessarily consistently picking or pulling in one site. There are some people who will pick and pull at others as well as themselves. So I have had patients who will pick and pull at a loved one or a romantic partner, usually. Sometimes at a child. A mother will pick or pull at a child. This is not considered something like a factitious disorder or a Munchausen's by proxy or anything like that. So again, you need to be aware of that. If mom is picking at her child's skin and takes the child into the dermatologist and is not saying what's causing the scabs because they're too embarrassed, that's not Munchausen's. That is skin picking disorder. So again, the mouthing is commonly involved regardless of who they're picking. And again, states can be various emotional states, no pain in the acts during the act. Again, this is very important, I think, to emphasize this. All right, for both of these disorders, these are most common in patients with OCD and first-degree relatives. So I think it's important when you see patients with OCD to screen for all of the obsessive-compulsive related disorders, but you will find that when you see someone with hair pulling or skin picking disorder, they are very commonly likely to have a first-degree relative with OCD. If you're not sure what's going on, you can get a biopsy, and a biopsy can determine if it is an OC-related disorder or if there's a medical cause. It's rarely needed, but I have seen some instances where people's picking is so autonomic, they're not even aware that they're picking. They're not even aware of what they're doing. And so they'll come in with lesions and aren't aware that they themselves are causing the lesion. So that does happen. The onset of the disorders is usually puberty. And importantly, like OCD, like body dysmorphic disorder, these are chronic illnesses. They're chronic. They wax and wane over time. They get a little worse at times. They get a little better at times. but they're chronic and lifelong. So all of the obsessive compulsive related disorders have that in common. These are lifelong disorders. They're with you your whole life. And I think it's important to note that, because too often I see people with obsessive compulsive related disorders. They say, I was diagnosed with OCD 10 years ago. And yet the mental health professionals don't put that in the chart, as if the diagnosis was old and isn't relevant for now. Again, you would never do that with someone with schizophrenia. If someone said, I was diagnosed with schizophrenia 10 years ago, but I'm not hearing voices now, you would never say, well, I'm not going to put schizophrenia as a diagnosis then. Again, these are just as chronic and lifelong as that. So I have given you at this point the clinical characteristics and features of the various obsessive compulsive and related disorders. Now I want to talk about the treatment of the obsessive compulsive related disorders. There's going to be a lot of similarities for all of these disorders. So all of the obsessive compulsive related disorders demand an integrated approach. And so what do I mean by demand an integrated approach? At no time is just using medications on someone with OCRD considered to be up to the standard of care. We always want to use pharmacotherapy plus CBT. And as in fact, if someone was only getting CBT for an OCRD and no medications at all, that would be considered to be okay. But at no time at all do we ever want to say our OCRD patients can get pharmacotherapy and they're good to go. So the pharmacotherapy just simply reduces their obsessions, reduces their urge to do a ritual, reduces the frequency, intensity of the symptom. And what it really does, it sets the table for the CBT techniques to work. And it's the CBT that really gets them doing better. We know that if you take a look comparing pharmacotherapy and behavioral therapy is at least as good as medication treatment for the OCRD. Behavioral therapy probably actually works better than medication therapy. That's why I said if you could only choose one, you would choose CBT. So for the obsessive compulsive related disorders, people who have moderate to severe cases, we usually prescribe both medications and ERP or the other CBT techniques. ERP is exposure with response prevention. I'm going to talk about that in a second. With mild cases, we can generally get away with just doing ERP or other CBT techniques by themselves. They don't necessarily need to have both if they're mild. So what type of CBT do we do for the obsessive compulsive and related disorders? So most of the CBT that we do for the OCRD is exposure with response prevention, ERP. And ERP is really the standard of treatment for OCD. It's evidence-based. We know that it works. The other various obsessive compulsive related disorders also use ERP, but they'll throw in some other techniques as well. So, for example, body dysmorphic disorder will also use ERP, but we'll throw in some additional CBT techniques as well. For the body-focused repetitive behaviors, we use what's called habit reversal training. And habit reversal training is really just kind of a fancy way of saying exposure with response prevention, with maybe a couple of other techniques added in. And there is specifically something called CBT for hoarding disorder that involves actually a lot more CBT techniques than some of the other OCRD, but there is some ERP in with that as well. It's important to note that exposure with response prevention, ERP, is not exposure therapy. There is something that's called systematic desensitization. Every therapist who goes to school in the United States is going to learn about systematic desensitization. And it's very easy to call that exposure therapy because you gradually are exposing people more and more to the thing that triggers them. That is not ERP. In fact, ERP is probably the opposite of systematic desensitization. So as a result, we have to be very careful when referring our patients to therapy that they're truly getting exposure with response prevention and not ERP. As of now, the only way that most therapists can get exposure to ERP is either by working in an OCD specialty clinic or taking what's called the BTTI, Behavioral Therapy and Training Institute, which are classes that are given on a periodic basis through the International OCD Foundation in order to train clinicians on how to do ERP. But if a clinician hasn't had that training, either one of those trainings, likely they're not doing appropriate ERP unless they've really have studied and learned from somebody else. As I said, it's not routinely taught. So medications. What are the medications of choice for obsessive compulsive related disorder? And it's SSRIs. And if that fails, it's SSRIs. And if those fail, well, we usually use SSRIs. So the slide is a little bit of a little sense of humor on my part, but I have a serious point here while I am talking about this. When we're using SSRIs for the obsessive compulsive and related disorders, we use the SSRIs very differently than when we use them for other illnesses such as major depressive disorder. So I am very intentionally calling these medications SSRIs. I'm not calling them antidepressants because, again, when we're using SSRIs for OCRD, we're not using them like they're antidepressants. So what is one of the differences is we know that according to the CATIE studies, for example, or the STAR-D studies, that when someone fails a SSRI, you might be okay with taking a second SSRI, but we usually recommend going out of class. So most psychiatrists are used to, boy, this patient failed fluoxetine, we better start them on duloxetine, or again, another medication outside the SSRI class. That is not the case with the obsessive compulsive related disorders. If someone fails an SSRI, we want to stick in class. We want to try another SSRI. We want to keep with the SSRIs. Moving out of class does not work very well for the most part in OCRD. So again, we keep cycling through the SSRIs. And I've seen patients fail 5 or 6 SSRIs and then respond to a 7th. That happens very commonly in OCD. So again, stick in class. Now, another way that we use SSRIs very differently in OCRD than when we use them for other things is dosage and duration. Okay, so the doses that we use for OCD are much higher. So here are the standard starting doses of these medications, but typically we take people with an OCRD up to the maximum dose. And it's probably a good idea for most patients to really go ahead and titrate them initially up to the maximum dose. I don't know that there's a whole lot of reason to try, for example, 20 milligrams of fluoxetine and see if that works. You pretty much bring them up to 80 milligrams. It's important to note that this maximum dose of this maximum dose that should be, let's call it the target dose for OCD, is often high above what is the FDA maximum dose. So, for example, sertraline, the typical target dose for most OCD patients and OCRD patients is going to be 400 milligrams. Again, a lot of psychiatrists aren't familiar with that, and they're perhaps not even comfortable with that because it's twice the FDA maximum dose, but these are scientifically recommended and validated doses for these medications. So again, this should be the target, the initial target for most people. Paroxetine, 80 milligrams. Fluvoxamine, 400 milligrams. Citalopram, 80 milligrams, but again, because of the FDA warning, we can't go that high. Escitalopram, 40 milligrams, and clomipramine, CMI's clomipramine, is the one tricyclic that acts like an SSRI, up to 250 milligrams. You'll notice that occasionally we'll go even above the maximum dose. So in some patients, we'll go as high as 120 of fluoxetine, 100 of paroxetine. I have a few patients on 500 and 600 milligrams of sertraline even. So the point is, sometimes with OCD, you have to take the doses up. There is another way that we use SSRIs differently with OCD is that you know that for antidepressants, if someone does not respond, to the medication, if they don't start to get an initial response within 3 to 5 weeks, you think about changing the medication, escalating the dose. That is not the case with OCRD. Get them up to the maximum dose. Once they're at the maximum dose, you wait at least 3 to 4 months to gauge a response. So again, those are the ways that we use that SSRI use is very different in OCRD. You stay in class. You don't switch for non-response. You're dosing much, much higher, and you're waiting much, much longer periods of time before determining a medication trial to be non-effective. So there are some specifics here for obsessive compulsive and related disorder that I think is worth knowing about for the individual disorders. So for hoarding disorder, there is some mixed data on whether medications work. Most of the data is with the SSRIs. And so I think if you're going to use medications for hoarding disorder, again, we recommend that you use the SSRIs. However, what seems to show the best results for hoarding disorder is the CBT for hoarding. So I think if you see a hoarding patient, you certainly can start them on SSRIs. And again, this is assuming that they don't have any other comorbidities that also need treatment. But referring them for CBT for hoarding probably is the best. Body dysmorphic disorder. SSRIs have the most evidence, perhaps clomipramine as well. Go ahead and use the SSRIs. Again, importantly, antipsychotics do not help with BDD patients, even if they have delusional insight, and in fact may be associated with a negative response. There is some data that if you have a delusional BDD patient, that if you put them on an antipsychotic, they do worse than if you put them on an SSRI alone. So antipsychotic plus SSRI is worse than SSRI alone. So even it's tempting with the way these patients may look to be delusional. It's tempting to want to put them on an antipsychotic, but SSRIs work the best in these patients, even the ones who are so-called delusional. For hair pulling and skin picking disorder, SSRIs have positive data. It is not robust. Clomipramine seems to have better results than the SSRIs. And so you can also consider clomipramine in these patients as well. We often avoid clomipramine because of tricyclic side effects, but there is some evidence, meager evidence, but evidence nonetheless that shows that clomipramine may be somewhat better in treatment-resistant OCD patients and OCRD patients in general. So that's always worth a try. Now, there is more and more data that NAC could be helpful at between 1,200 and 3,000 milligrams a day for the body-focused repetitive behaviors. So I still recommend that SSRIs are used first, but I think NAC has a real role to play. It can be an augmenting agent. It can also be used as a standalone agent. It's important to note that some people I hear are using NAC as an augmenter for OCD as well. And I just want to caution you that the meta-analysis really show the opposite. NAC does not appear to work very well as a adjunctive or augmentation medication for OCD. NAC works in hair pulling and skin picking disorder, but so far with the obsessive compulsive related disorders, that appears to be its only use. So again, would not suggest using NAC for OCD. There is possible role for olanzapine. There is some data that shows that olanzapine may be helpful for the obsessive compulsive and related disorders as well. And I want to finish with my treatment algorithm. So this is a treatment algorithm that we developed at the University of Pittsburgh. And what this essentially says here is that if someone has a diagnosis of OCD, we can use for mild to moderate patients, you can use CBT alone. For moderate to severe patients, we use CBT plus an SSRI. We never use SSRIs alone, though. If someone fails an SSRI, you can move to a second SSRI. If someone fails that second SSRI, generally at that point, we can recommend go ahead and try clomipramine. If someone has partial responses to an SSRI, a perfectly good first-line augmentation is to augment them with a little more clomipramine. So if someone is on 80 of fluoxetine and they're doing well but not well enough, you can augment that with clomipramine. So what do you do at this point? Well, if they have a trichotillomania or skin picking disorder, you could consider augmenting with an acetylcysteine. You consider augmenting with NAC. Okay, assuming that they don't have the body-focused repetitive behavior, my second line augmentation is augmentation with glutamatergic agents. So memantine and riluzole are the two that were used most commonly. I recommend augmenting with glutamatergic agents. The data is becoming better and better with those agents, but the side effect burden is so much less than antipsychotics that I think that it really is more advantageous to use those medications. You can consider ondansetron. There is some evidence showing that it can work for OCD augmentation. It's low risk, so it may be worth a trial as well. Now, again, if they're getting no or partial response to that, you can switch to a different glutamatergic agent or consider an antipsychotic at that point. So you're aware the antipsychotics we generally use that have been studied the best are either aripiprazole or risperidone. We sometimes will use quetiapine or olanzapine. And those are really the only four of the second generation antipsychotics that have been studied in obsessive compulsive and related disorders. So there isn't really a good reason to use any of the other newer or other second generation antipsychotic medications. So it's those four: aripiprazole, risperidone, quetiapine, or olanzapine. Again, if they have a body-focused repetitive behavior, you can consider olanzapine. Also consider buspirone. Buspirone is, again, some data with augmentation, low risk, worth trying out. When people get no responses to that, we'll switch antipsychotics. We'll use second-line antipsychotics, which are essentially first-generation antipsychotics. We can try anticonvulsants. There is increasing data looking at things like lamotrigine that may be helpful at certain times. There are other glutamatergic agents you can try. You can try combinations of augmentation strategies. And notice, retrial of ERP. If someone is not still in ERP, we go ahead and retrial them. Someone is considered treatment refractory only if they've failed 2 full therapeutic doses of SSRIs, if they failed a full therapeutic dose of clomipramine, if they have failed 2 augmentation strategies, and 10 to 20 appropriate sessions of exposure with response prevention. We will try new surgical intervention techniques that have various degrees of approval, a little bit beyond the scope of today, but things like deep brain stimulation. There is ablative surgery as well, and that we can do to help improve OCD symptoms. Okay, and that is my last slide, and thank you for paying attention.